Welcome to Delhi, all of you.
Thank you so much, and we're looking forward to your case.
We are just waiting for the first slide to come. The lady is an elderly lady. She's a diabetic and hypertensive.
Okay.
And she's been having ischemic heart disease for last almost a decade.
Okay.
The first intervention she had was in 2007. At that time, she had a stent in the circumflex artery.
Okay.
After 3 years, she had a stent in the LAD. And she's been asymptomatic in these for last 7 years. So she came to us with a chest pain on exertion and NYHA class 4 for last 15 days.
Okay.
Her first angiography was done on 27th of November this year only.
Okay.
Can I see the angio, please? That's our RCA. Run it, please. You see, there is a mild disease in proximal RCA. The distal RCA, the PLB is fine, and
Very tight PDA.
and the PDA has got diffuse disease
Yes.
proximally.
Yeah, osteo, the PDA is tight. Okay.
Next, please. Calcified. The last OM, which was stented in 2007, shows a tight proximal stenosis. Next, please. And see the LAD. It shows a diffuse disease proximal to stent, in the stent, and distal to stent.
So new disease involving the diag.
And
proximal
distal LAD
and
has got
distal.
diffuse.
Yes. Okay. We see it well.
Yes. But the proximal vessels are looking fine. So at that time, the initial intention was to, this was the last month.
All right.
A week back. Right. To do the circumflex artery.
Okay. So the circumflex has been
Right.
completed
Next,
already.
please.
Okay.
Yes. It was done last month.
Okay.
So next, please.
And your technique there was just to do
It was
provisional
difficult
stenting.
ballooning.
Yeah, just ballooning it. Okay.
Yeah, it was ballooning, but the ballooning was difficult. The balloon was slipping up and down. Next, please.
So this is an ISR of a prior circ.
Just see the main lesion was proximal to stent, but it was expanding into the stent also.
Okay.
Right. It was difficult dilating with a high pressure balloon. Next, please. So after a good struggle about 10 minutes, we could achieve a good result with the balloon. Then ultimately we decided to put in a stent because it was high pressure dilatation in all the areas.
Okay.
Next, please. It was a 2 into 18 millimeter stent.
So this is a 2 into 18.
Deployed at reasonably high pressures.
Okay.
Yes. It was not covering the full stent which was put previously in 2007.
All right.
Then a high pressure dilatation was done, taking a 2.25 balloon. Next, please. And it was a reasonable kind of result at that time. And
So
we attempted the LAD also at that time. The LAD, and we could only do the balloon. Right, there was no place for the stent. It was all diffuse disease.
All right. So your circumflex
So
result
she
is
improved
good.
after the procedure.
Yes.
Yes. Right. So we are not showing the like a LED lesion. So now she was like
So we'll have a
discharged.
discussion
Yeah.
on what we did. है ना?
Discussion next time when she comes
पिछले वाले
back.
केस का कर लो.
Yes.
हाँ. So would you like to make any comments on what we did last time?
Well, I mean, I think that you treated. She had stable ischemic heart disease with prior PCI. You treated one of at least three areas that could be treated. The LAD needs to be treated as well at some point. It'll be in a stage fashion, and then the PDA would depend on her symptoms after that. The PDA is quite diffuse and small, but it depends on her symptoms.
So the issues involved in this case were that this is a diabetic patient. There is stenosis, maybe a restenosis in the proximal edge of the previous stent in the circumflex. And since the balloon was slipping backward and forward, there appears to be a relative amount of fibrosis.
Yes. Yeah, it's a fibrotic
So
lesion. Yeah.
now this balloon, which was, it's a very fibrotic lesion. And so we could also have a discussion with the audience on choices of therapy when you have a fibrotic lesions. How do you like to prepare your bed in such cases?
Atul and
Because
Praveer.
here, this is a classical teaching case. Yeah.
Yeah. So this
Where
is
you see the balloon was melon seeding forward and backward, causing an injury to the proximal and distal beds.
So this is Ramesh, but let me take you one step back. Why not bypass surgery?
You see, the distal vessels are too small to be bypassed. LAD is has got diffuse disease, and the PDA all along is diseased.
Okay. So there was an.
If you just go back to the angiogram, let me.
Okay. So let's take it that it wasn't.
There's
a-
and
it
she's an
wasn't a
obese
surgical
lady,
case.
diabetic.
So Atul's question, Dr.
No, it wasn't a surgical case.
Yeah,
in
it's
any way.
very more of distal disease.
So Dr. Mathur's question is, how would you pre-dilate a fibrotic lesion? Anybody would choose?
Yeah, so you can take a call from the audience and have a discussion on it.
Yeah. So watermelon seeding of the balloon obviously causes injury to unstented areas or areas you don't want to treat. And the question is how do you keep it there? Typically, taking longer balloons will help. Sometimes non-compliant balloons, but we use specialty balloons in the United States. We have two of them, the Angiosculpt. We also have the cutting balloon. We also have a third called the chocolate balloon. These are balloons that have some sort of mesh either around them or a constraining mechanism to prevent slipping. They're expensive balloons, and they're not low profile, so I'm not sure it would have crossed in a case like this.
Grip balloon.
And those are options
grip
that we
करने
would
वाला।
use.
Gripping room वो है नहीं।
Anything from the panel?
करने दो बात
The only thing we want to just tell you,
Yeah, go ahead.
yeah, was we did not do any imaging at that time.
Okay. And imaging clearly. In
She was
small vessels
discharged
is helpful.
after a couple of days. She was fine.
Okay.
Yes, and she came back 2 days back in the night with acute chest pain. Can I have the next slide, please?
Okay.
You see the clear ST elevation in 2-3 and AVF,
Yeah.
पहला शॉट दिखा दो आज का।
Okay. So she.
and we were
represents-
thinking that this may be an acute occlusion. Considering the acute occlusion, we are planning to take to the lab, but as we are preparing, she had. Can we go back?
Yeah, there you are.
Can we go back? Yeah. She started settling down. The issue showed complete significant improvement. Next, please. See that CC is completely settled. The pain disappeared.
Okay.
So we did. So we did not take her in the night. We waited till morning and see what happens. Next, please. This obviously the stent is completely occluded. And if you notice, the stented portion is fine, the occlusion is beyond that.
So you have abrupt occlusion beyond the stent, which is most likely some sort of a dissection that was not detected at the time of treatment, and you have an occlusion there, okay?
This is most likely due to the melon seeding of a previous balloon when we were dilating.
Yes, which was going up and down.
Okay. So what was done?
Right. Now let us see the, you see, we are now live. Like we had, now the whatever you say, we'll do that.
No,
So-
can you show the right?
So will you show the angiogram, the first angiogram?
Yes. Right, we have not seen. We are just treating this lesion right now. Right is exactly the same.
I mean, I think watermelon seeding, dissection is one. I have seen somebody like this with multiple vessels actually have spasms as well with the acute ST elevation MI. Couple of times she presented with ST elevation MI. So, I mean, obviously we are going to give nitro, to see.
All right, so let's take a poll. So if this is the problem target
So-
today, Mark, how do you deal with this? Patient comes back after a 2.0 stent in a
Yes.
in a distal circ post dilated 225 with symptoms. What do you do in this case?
Maybe you would be surprised, but I would have not touched this circumflex, either the PDA. As you said, there are small vessels. I always try to think before what will the surgeon will do. As you mentioned, we could have sent this patient for surgery, but he has diffuse disease on the LAD. So I would have fixed the LAD only and leave the other two vessels to the medical therapy, because
Okay.
it's a typical mace because of the size of the stent, which is too small.
Totally
with
agree
the
with you.
poor distal runoff distally. So we have not touched this, but once it's there, either you can leave it alone because it will be a small infarction distally, and I'm not sure we will get any complication.
Was there a troponin leak here? Did she have a troponin that was positive?
Troponin.
Troponin is positive.
Okay.
You can leave
But
it
she's
alone.
pain-free at this point.
Troponin
But
in
there's a
our
good
lab,
collateral. Yeah.
I
Okay.
think I will leave it alone.
Okay.
and
so-
it's significantly positive. It's,
okay.
Because what are you going
But
to
there's
do?
a
to
good
do
collateral.
but we decided not to leave it alone.
Okay.
Right.
so-
Because
okay,
we know that this ST elevation which was there last night
Yeah.
was because of the vessel.
Okay. So what's your plan?
So what we did was initially we tried, initially we tried a BMW wire.
Okay.
So this is the picture now, you know.
Yeah. It was difficult to negotiate, so we have to resort to a whisper wire to go down. Next, please. Then we just did a dottering with the balloon.
No.
Next, please. To just see the lumen. Right? Next,
Next.
please. Yeah. Next. Then in this path, we passed the BMW wire.
So I like the fact that you dotted and didn't dilate, because you want to make sure that you're not subintimal, and you don't want to inflate if you don't know if
Yes.
you're subintimal. So I think that dottering it makes sense if
Yes,
you're going to go after
absolutely.
this. You used a hydrophilic wire and a whisper.
Yes.
They are notoriously good wires, but good
Yes.
wires that'll get subintimal. And you see
I
now
know.
a haziness at the outflow of
Yes.
the stent, which either is thrombus and a dissection
Yes.
or a dissection. Okay, go ahead.
And
the
at
other-
this point,
No, the-
we did an IVAS.
See, the other reason why we dotted was that we wanted to make sure that the IVUS catheter would pass freely over there.
Sure. I mean, the IVUS catheter would be nice to pass, but you want to know that the wire that is down is not
Yes.
mounted into subintimal space. Okay. So what did the IVUS show?
So now the IVAS, we will show the IVAS run. Yes.
Yeah. Okay, you can go live. Want to speak? Can you show the IVUS, please? Can you show? Yeah, restart the IVUS.
You see, the distal vessel diameter is appearing about 2.25. Keep running.
There is a significant amount of fibrosis now that you can see.
Now
you're
here
in-
the stent comes.
now you're
It's
in the
grossly
stent.
underposed, underdilated. Yes. And a lot of fibrosis around.
So this is the old stent that we are seeing.
And now you can see two struts, like two layers of stent.
Okay.
And both are underexpanded. The vessel is reasonable size, about 2.5.
Okay. So
And the whole of the length of the stent is underexpanded.
so you have an outflow plaque disruption and a small vessel. You have a 2.0 stent which is underdeployed, and the proximal 2.5 stent is also underdeployed and
Yes.
a large proximal circumflex.
Yes.
Which lends to a recipe for
So
further events. You've already had one event. but-
acute occlusion. Yes.
Yeah.
Okay. So how will
Can
you
we see the
manage
next
this?
view now?
Okay.
Now we next
The
next
angiogram.
slide, please. Show the angiogram. Now what we have done is we have gently next please. We have gently done a 2 millimeter balloon, very gentle, about 2-3 atmospheres, and see the vessel coming up. It's a not a very small vessel. And next please.
Well, it's big enough to cause ST elevations.
Yeah.
You clearly have a disruption
right.
at the
Yes.
outflow.
Yes.
So
Now
what's
seen
your
the
plan?
IVAS.
yeah.
What does the panel say?
Yes.
What we should do now?
What does the panel feel that how should we go about?
Okay. Anybody in the panel? How do you want to manage this now that you've tackled it? Yeah, they've dilated it to 2 atmospheres with a 2.0 balloon.
Can't hear you, Sampath.
Just bring your
Underdilated stent. I think we should post-dilate the proximal stent with the 2.5 balloon and then just distal another one more 2.5 stent. Cover the
okay.
whatever dissection portion and the uncovered part of the vessel.
Delty, what do you want to do here?
I think if I recall the last procedure which I did about a week back,
Okay. So what we're
it was
suggesting
distal
is that-
dilating this distal part of the lesion.
Yeah, we want you to expand the other stent and put a short 2.5 stent and make sure you image it and don't leave it outflow dissection.
That's fine. Only thing is that before putting in a stent, would you just dilate the previous stent first, or you?
Yes, we would.
We are underexpanded. you know?
Yes.
That's the issue.
Yes, absolutely. I would
So
go
shall I take a
aggressive.
2.25 balloon or 2.5 balloon?
2.5 NC.
Yeah.
2.5.
Yeah. So maybe the distal will dilate with 2.25.
Yes.
The artery is not that big.
Yes.
you know?
So let us
this
have a
we can
2.
take out.
Oh, yeah.
2.5. High pressure balloon. Yeah.
Anybody in favor of a cutting balloon?
There is significant fibrosis, but it is outside the stent.
Well, you just implanted the stent, so I think you should be okay. You can use a cutting balloon, but I don't think that you need to at this point. You want to stay well away from the edges, but at this point you're going to re-stent the outflow anyway, so make sure that you get the stent down and expand the prior stent.
So
We have to be careful not to have a rupture.
so what we have is a Mozek
That's the most
NC
important thing.
2.5 into 12, 13. 13 millimeter balloon.
And would you like to repeat an IVAS before putting in the next stent?
I don't think we need another IVAS. I think pre-dilate or.
So we'll probably do an IVAS at the end of the procedure.
Yeah, sure.
All right.
So we are going ahead with a 2.5 into
13.
13 mosaic NC balloon.
Okay. Want to go on Cine?
We'll come back.
You have to go beyond also, but
beyond
we'll
to-
not dilate.
no. Yeah, I'm
So-
coming back inside this stent.
Yeah,
So this
just
is going to
stay-
be within the stent dilatation.
Just stay within the stent.
Okay, go up. 1, 2, 3,
Yeah.
4.
Even with all that, I think
5,
our
6.
TBR will be about 20% in this patient. But for this vessel, we're very
7,
small.
8,
You won't know it because
9,
she's already
10.
had her infarct.
11, 12, 13, 14.
So distal
14 and
part
a
is,
15.
there's a
15 and a half,
fibrotic area
16.
over there.
Yeah.
Is she having any pain? That's the most important thing I
In
want
the
to
distal
ask.
part of the balloon.
Right now,
Yeah.
she's been sedated because she was having a lot of discomfort while lying on table.
Okay.
Now, can you just notice the distal part of the balloon is not fully expanding.
It's okay.
Let's do a proximal
Yeah.
dilatation also.
Next, deflate.
So a little dilatation in the proximal part of the balloon also, stent also.
Yeah, I would go higher here.
Go up. 6, 8, 10, 12. 13, 14.
The patient
15,
has some
16.
pain during this dilatation.
Well, that's good. Serves a purpose for doing it.
Or height. This is
16.
2.5.
Deflate.
Even then there's some indentation.
Yes.
You know?
So now I'll be just slightly go ahead once more and keep it inside just at the edge. Yeah, go up please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14.
So here we are within
15,
the old
16.
stent.
17, 18.
Sene, let's see how much
Make
it
it
is
up.
opened. That part hasn't opened, huh? Distal part.
Deflate.
So maybe a 2.25 at a higher pressure, because this is a smaller artery.
Well, let's take a picture.
Yeah. All right. Right. So the distal old stent is still under expanded. You can see some haziness over there and some dissection beyond the edge of this old stent.
I'm not sure I would dilate any more down there. I didn't see calcium.
Yeah, it's a
in your
smaller vessel. I
ibis.
think it's a 2.25 distally. No, there was no calcium.
It's all
mostly
fibrosis.
Yeah, and it's a typical diabetic vessel which looks small on the angiogram, but on the IBUS you usually find that it's a little bigger than that.
So at this point of time, what do you say? Should we go with the stent now?
What do you think, Ramesh?
I actually, I mean, these vessels are so diffusely diseased. No matter what we do, the outcomes are not so great, in my opinion. But yet, we are here in a situation where we have to put the dissection, which is STEMI, and I would put a 225 stent. I don't know whether it is 2.5. The worst thing to happen is actually get a perforation with this lady, and I would put a 225 stent and post-dilate and get out.
Yeah, I totally agree.
Yeah,
So
I think
I
that's
think
a
we
good
also
plan.
agree with that.
So we'll put this second stent beyond the recently put stent. We'll not put too much metal proximally.
Correct.
There's already 2 stents proximally.
Just enough overlap. Just enough.
Right.
Right? Can we have 2.25, 13?
Just enough. Yeah. How much length?
Okay, we don't have 2.25, 13.
So what do we have? 2.25.
We have a 213, I think.
No, we need 2.25.
You
Evermind
see,
le lo.
the Evermine is a stent which has got thinner struts.
Le lete hain.
Yeah, we have got 2.25, 13, right.
Ever.
Yeah, give it. Yeah, it's fine. And the strut thickness is hardly 50 microns. So in a smaller vessel like that,
Less metal.
yeah.
So what are the previous stents that we have used?
The previous stent is, the first one was Zines. And the second one was I think this was Yukon, because of 2 millimeter stent. Because you don't have much options in 2.
Yeah.
Okay, so this is a Evermind 50
So this time
micron.
yes.
All right. one midas, one more.
अभी आंटी बस 2 मिनट.
We want to get to the first stand now. I'll show you a check now.
हाँ. Can we take a
Can we see the angiogram, please?
whiz?
Can we see the angiogram, please?
Yes.
Yeah,
Minus,
please
go back minus.
go to the
please.
angiogram. हाँ.
Go back minus.
थोड़ा सा और पीछे लेना पड़ेगा है ना?
Go back minus.
So it went down
Next.
easily.
Forward.
Should we take a whiz?
हाँ. Okay, now we'll take a shot for the whiz.
Yeah.
है ना? Whiz कर लें.
We'll take a stent whiz to see that how much we are protruding the proximal stent.
Okay.
Okay.
This is a form of stent boost called stent viz.
Yeah,
Yeah,
it's a-
it's a yes.
so this is the G machine. So they have the stent whiz.
The frames are less. Just hold on.
Take a little longer run.
Yeah. Yeah, now it will come.
हो रहा है whiz? All right. Yeah.
So we're waiting for the whiz result.
We want to give a very fine
Yeah.
overlap over there.
You just have
No, this is the old stent. है ना?
yeah.
Probably we need
And
We
the
have
new
got 2
stent.
minutes. 2 minutes.
Just a
one
little
and a half
back. है ना?
centimeters.
हाँ.
we need to
1 or 2 millimeters. Agreed with you.
You
Yeah.
need to come back.
Yeah.
Yeah, I'm coming back.
All right. So there we are. On a cine.
Yeah,
No.
check. I think it's okay. Is it all right?
Freeze करो.
You have to tell us. It's hard for us to see.
Go back.
I mean, we couldn't
हाँ.
see the
Yeah.
No, we need to
The
come
whiz
back.
is looking
It's not
fine.
yet. It didn't come back.
That looks good. Yeah.
Yeah.
Okay.
Yeah. That looks good. You want to go up?
Yeah. Go up.
Go up, please.
1, 2, 3, 4.
So that what they're
And
trying to
gentle
achieve
deployment.
is
5,
overlap with
6.
minimal overlap.
7,
And the critical thing
7
here
and a
is
half,
to make
8.
sure you hold the stent so that it doesn't
8
slip.
and a half, 9.
Typically what I do is I go to nominal, come
Deflate.
down, go up again, come down, then I can bring the balloon back
Pull
a
back.
millimeter and then go high.
This is what we are exactly following. Okay, go up. 1, 2, 3, 4. 5, 6, 7, 8. 9. Deflate. Go up. 6, 7, 8, 9. 10, 11, 12. 13, 14.
So it's a compliant balloon. है ना?
Deflate.
So
No, it's not. It's a semi-compliant.
semi-compliant. So we have gone to something like 2
Yeah.
point.
Go up. 6, 8, 10, 12.
All right, then you can take a
13,
you're gonna
14.
take a non-compliant balloon anyway. So
15, 16. Yeah.
Yeah. Now we are going to do that. 2.5. दोबारा
See
ले
the
लो.
area in the middle where the previous stent is? Still, I'll show you again the cine. Right? Deflate, please.
That's a haziness there. है ना? So you think that's a
Yeah,
little tissue
that area
prolapse
still is
over there?
hazy.
well, you'll have to look by
And
IVUS
this is
see-
the only area that we are concerned. Yes.
Yeah. So first we'll do a 2.5 with this stent and then put in an IVUS. है ना?
I would post dilate first.
Yeah. Praveer.
Because we were really avoiding Yes,
Yeah.
we are avoiding the 2.5 balloon in this area because of fear of distal dissection. And this was the culprit last time also, and I think this time appearing the same. So we are going with a 2.5, same balloon. We'll keep it slightly inside.
Yeah.
Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Deflate, please. I'll come back a bit more. So the distal vessel is avoided. Yeah, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18.
Cine.
Still not given way.
Yeah, need to go higher. You know? I think it's a vessel is 2.5.
So this is a 2.5 balloon?
This is 2.5 balloon. So should we go for the?
Yeah.
Yes.
I would IBIS this before you go any higher.
18
It
and a
can-
half, 19.
Or go-
Okay, fine.
or
Deflate.
take- or take
That's a
this
good idea.
higher
Proximal
pressure.
edge. We have done. You know? Yeah, we've already done that. Maybe we'll take a focal balloon and
We'll take a focal balloon in case it's not going with me. Yeah.
I was ready.
So we'll do an IVAS run now.
In cases like this where I find
Sort of
focal under expansion, sometimes the focal balloon will not expand, but that's a good chance, good idea. And the other thing I will often do is take the angiosculpt balloon, which can go up to 30 atmospheres, and sometimes that will release these fibrotic lesions. But that's, you're hoping you never have to do that. Let's see what the IVIS
Yeah,
shows.
will flush. Yellow. Your IVIS. Flushing.
Yep.
Let's check whether you have a cover.
All right.
Right?
Mark, in France, what are you doing with underdeveloped, underexpanded DES restenosis that you can't expand? What are your options?
Of course, it depends of the localization of the lesions. I think we have a trial, I don't remember the name, but comparing bypass, redilate with the balloon, redilate with the second drug, and the surgery is doing the best. But if it's,
Okay,
for
काफी आगे आ गए,
example,
थोड़ा
a single
पीछे ले।
vessel for OM,
बहुत distal आ गए।
I will try to
बस।
put a second
Good.
stent and change the drug, even if it's not
But
very
what if
scientific.
it doesn't expand? What if you have a DES ISR?
Under expansion.
Yes.
I think once it's done, it's very difficult
Can we go
to
live
achieve a perfect
with
result.
IVIS?
The
We'll
mistake
have to
is
start
from the
again,
beginning. Then you can try to post-dilate
Yes, sir.
or with very
Okay,
high pressure.
ready?
But in my experience, once it's done for the first time, it's difficult to
Pull back.
achieve a perfect result.
So in our laboratory, we do see a lot of DES ISR referred in. 50% of them are underexpanded.
Just have a look at the IVAS, please.
And the ones that are not not able to be expanded, we will sometimes last resort use laser.
You see the same area of fibrosis still persisting.
Right.
But proximal stent is well expanded now, but that area remains the same.
So there's no gap. It's just underexpanded.
I haven't found laser to be actually very useful. And I think in case
It's only
of
it's only in
2.5
calcific
8
cases after
quantum,
stenting.
yeah.
It's not used for anything else. But in this case, what are your options? Your options are to take
2.58
a
quantum level.
non-compliant balloon at
Short.
30 atmospheres and potentially cause rupture, or to take a constrained balloon higher up. But anything you do here is going to be fraught with problems.
Absolutely. I think some people have tried even rotoblading. Freshly deployed under expanded stent, they rotobladed and they destroyed the stent, then got rid of the calcification behind
Stop.
the stent. And then
Okay, we'll have a replay of
Okay, so
IVIS once.
so what will you be doing? What's your options?
All right.
I think we have to take a focal balloon
Okay. So 258
And try that.
balloon. NC.
Yes, 258 and see.
So here, really getting high pressures is very important.
Ah.
I will go to 24, 26. The quantum is very resilient.
Yeah, I'll take it now. Yeah,
I have not taken
yes.
a mosaic up that high, but that's just because we're using the mosaic.
no, I
for
will not
long
take that. I'm just taking.
क्या लिया? Pantera. Okay.
This is a Pantera Leo, which is a very, very non-compliant balloon.
runs. Okay.
Just the same class as your quantum, and all right, go.
I hope it doesn't slip.
No, I won't slip. I have full confidence.
Okay, let us see. Can we check?
Yeah, all right, let's do it. I'll fill up the syringe and ready.
Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 21 and a half, 22, 22 and a half, 23,
It's opening up. You can see some.
doesn't appear to be.
ये थोड़ा खुला है पहले से.
23 and a half, 24, 24 and a half, 25, 25 and a half, 26.
Okay, all of you hold your breath.
It's trying.
26 and a half, 27.
Seems better, but there's a little indentation.
No, it's a good indentation still persisting.
I want to take it back a little and then again go up.
Still, it's like
in
it's
the
a
middle
center.
portion.
You
Yeah.
see this?
Change the position of the balloon.
You see this?
Yeah. So
27,
and hold it for a longer time.
27 and a half, 28.
So sometimes holding a balloon at high pressure for a longer period of time, if the patient is tolerating, can help in such resistant lesions.
28 and a half, 29.
Another view,
Yes. Should we take another
Eliocaudal?
view?
Eliocaudal or
You
something.
can.
Go to iliocranial.
My other option would have been to come back a millimeter and
Keep
go
the balloon
higher.
in center.
More aleo, more
Yeah.
aleo. Yeah. Now I think we won't go any further high. Go more. Okay. Come back to this side. Come back. Come back. High. More aleo, more aleo,
हाँ,
more aleo, more
बस,
aleo. Yeah.
ठीक है. That's
Stay
it.
here. Stay here.
Let's have a center.
It's appearing better, but still the center is not looking all right.
Well, you're doing a great job with ischemic conditioning.
Yeah.
Yeah.
There were some good collaterals from the distal LED coming to
29
this OM.
and 30.
The lateral wall
So
is
that was
moving-
one of the reasons
moving
which
just
prompted us to
fine.
do this vessel. Yeah. Yeah.
Deflate. So now
Slowly.
let us check in this view whether we have not caused any perforation.
Okay. So there is a little indentation at the same point.
Looks better.
Dizziness.
Better than before.
Okay, now what?
Can you check in the other view?
Yeah, only better. Ariocaudal,
Okay,
please.
ariocaudal again.
And let us do the whole thing with 2.58 the upper.
You can go to higher pressures. All right, you take a shot.
The only other option here is to take a different balloon, but I think just do it little more proximally at a higher pressure. Keep it there again. The other option is to take an angioscope to 30. The final option would be, if you actually needed it, would be a laser, which I wouldn't recommend here. I think you do the best you can.
What about the ratio between benefit and
We have the laser in the
That's correct.
lab.
You've already spent a lot.
I don't know how much time it would take to set it up.
I don't. I mean, as I said, I don't know whether
should we set up
laser
the laser?
will work.
We'll see whether we have.
As you were saying, I call it quits
Yeah.
here. Let's get out of dodge, and this patient will come back, and at that time
Yeah.
I'll have a controlled infarction, meaning letter infarction.
I know.
And pain management.
Well, how about the LED
Yes.
diagonal? Are you going to do the LED
I
diagonal?
think
At some point?
LED diagonal, LED we have done it with the balloon is doing all right. And
This should be lower pressures.
We-
It's a small vessel.
yeah. 1, 2, 3, 4,
Plain RO.
6, 8, 10, 12. 12.
I think the LED diagonal could be treated
Deflate.
nicely.
LED is diffused these vessels. Balloon is staying open at the moment, so we are not touching that.
So if she comes
And
back,
diagonals, yeah,
she comes back for the LED, then I think drug-eluting balloon may be a better choice.
yeah.
It's not a good case for stents.
Go up 6, 8, 10, 12.
Maybe at the end we'll give
14,
you a
16,
final
18.
picture of the LED, how it looks like, so you could have some discussion on it.
Deflate.
According to the fibrotic feature that you find
Go up,
in
6, 8,
this
10, 12.
circumflex, what will be your
14,
strategy?
15, 18,
of
21.
in the LED, do you think you have to start with the looking first or just
I
dilate?
think in case
It has
there
to
is-
have, like, supposing you want to get a good result, it's a drill. It's a root ablation. That will help.
or maybe a cutting balloon.
Cutting balloon with,
If there's not much
it
calcium.
might.
Yeah.
You don't
Deflate.
do much debulking with cutting balloons.
What do you guys think?
I think the LED will
We
be
No,
do
we
that
do,
deal of bulking also, but cutting balloon is not a very good option for a long tubular, these kind of fibrosis.
Yeah, my recommendation would be to image with
Go up.
the LED, so you know exactly what you're doing.
6 and 10, 12, 14, 16, 18, 21. I'll show you the image.
Yeah. In fact,
Deflate.
before we started this case, we were discussing cutting balloon for it. But there, in this
Go up.
situation, the
6 and 10,
fibrosis is
12.
more outside the stent, so we did not really push for it.
46 and 18, 21. Deflate.
So patient is tolerating these multiple inflations very
6
well.
and 10, 12.
Probably ischemic preconditioning is
46,
the right
16,
word for
18,
it.
19, 20, 21.
Okay, so we have about
Caudal,
4
caudal.
minutes left in our transmission.
All right.
All right.
We'll give you one shot of the LED and one good shot of this
Deflate.
circumflex. And maybe we'll do an IVUS before we get off the table, just to make sure what we have left. So whatever we can show live, we'll bring it to you right now.
Okay.
It looks good, cranial.
Now let us see the LED. Epicranial,
Epicranial.
epicranial, epicranial.
LED
Center.
देखेंगे, हाँ? It's a diffusely disease till distal, है ना? Till the apex. It's a disease.
Yeah, it's an important territory.
What do you
though.
say should be the plan for the LED?
Well, I think imaging will help. I think there is calcification. I agree. I don't see much calcium before the stent in
Yes.
the LED, but I think that pre-dilating and imaging will
Distally,
help
there
you,
is a chunk of calcium.
and I think
yeah.
you're going to need to stent
Yes.
that whole segment. Unfortunately, it's diffusely diseased.
Or if she develops disease back in the circumflex, maybe we'll also have another discussion with the surgeon.
Might be
Because
an
there is a
option.
PDA, there is a diagonal, there is a not much of distal LAD, but and there's a decently sized obtuse marginal, you know, the one we have treated today.
Absolutely.
Atul, I'll vote for surgery.
But since the
even
lesions
now.
are not proximal, yeah.
Yeah, there's
Done.
no, there's no, there's
No,
no,
we
yeah,
accept your advice.
Yeah, there's no good answer here, but again, this is what we face with diabetic disease.
Yes.
Any questions from the panel?
Yeah, if
Final
you just see
thoughts?
even PDA is non-graphical vessel.
Yeah. Questions from the audience? Yes.
This is Dr. Asadullah Hassani. Just I want to have a question
बात
regarding
कर लो, हो गया कह दो.
if again the LCX stent becomes with stent thrombosis.
Hyvus करना है?
So what should be the choice after that?
Leave it alone.
I think it's a very difficult question to answer because she might be having a repeat episode of thrombosis. And I think we
would
have to
put-
manage it medically now. You can't go ahead again and again.
What were the antiplatelets she was on?
She was on
Clopidogrel or Brilinta or something?
she's on clopidogrel.
Yeah, I would change her to ticagrelor or Brilinta in this case, and I would see how she does.
Yeah.
Do the best you can.
Yes.
We want to thank you and your team
Right.
for a very difficult case, challenging case. This is an everyday live case of what we see in our practices, and we'll see you later. Thank you very much, both of you.
Yes, see you.
Bye-bye.
Say goodbye.